Welcome to the third part of this playlist on Mastering Endodontic Diagnosis course, and now we will head straight to the Pulp Vitality Test. Check out the entire playlist if you missed anything so far. So let's start with the first section, which is going to be Pulp Vitality Test. So out of the 4 types of tests that I mentioned for endodontic diagnosis, Pulp test is the first and the most commonly used. If the patient has a chief complaint of cold, then you would start with a cold test. If the patient has a chief complaint of heat, that with a hot coffee like this, their teeth hurts, then you would perform a heat test. And if you think that you might want to find out if the tooth is dead or is it alive, then and there is no chief complaint based on heat or cold, then you go for an EPT, which is electric pulp test. There is also a very specialized test which is called laser Doppler flowmetry. Out of these 4 tests, the most reliable, actually 100% reliable test is your laser Doppler flowmetry test. But that's not practical. That's not something that we have in the clinic. That's why it's not useful. But somehow our dental board exams and our competitive exams love to ask us question on this laser Doppler flowmetry test. So for the sake of that, we will include this in our lecture. All right, let's come to the cold test. The patient has a chief complaint of pain with cold, and they have a lingering or not so lingering pain, but it only comes when they heat ice cream or ice cubes or some cold drink. Then we have to find out if the patient has complained with only this one tooth, but you would keep the one teeth distal to it and one teeth mesial to it, anterior to it, as your baseline teeth, and for all those 3 teeth you will conduct that certain cold test. So for doing the cold test, we have few options. You can do carbon dioxide sticks. Carbon dioxide, if you know, it's called dry ice, and these are super cold. And you can use these carbon dioxide sticks. There is dichloro-difluoromethane, which is DMD, or more common endo ice, which is called tetrafluoroethane, or tetrafluoroethane is more commonly known as, our commercial name is endo ice. Then we have ethyl chloride spray and ice sticks. So the very common question that is being asked in these exams all the time is, what is the temperature of certain type of cold test? They want to know that how much do you know about cold test, and how much have you explored the different options available in cold test, and do you know the limitations of those cold tests? So let's look at the temperatures first. For carbon dioxide stick, that is going to be the coldest. Dry ice will give you the coldest temperature, which is negative 78 degrees centigrade. The next is endo ice, which is actually something that we use a lot at our dental school, and the temperature that it offers is negative 50 degrees centigrade. After that, ethyl chloride spray gives you negative 5 degree, and least cold among all these is the ice stick, because yes, ice is frozen at 0 degree, but once you take it out and you hold it in a tweezer or in your glove finger and you take it in there, it comes little bit above 0 degree, which is not a temperature that you are looking for when you are doing a cold test. Few things to remember about each of those. Carbon dioxide or dry ice sticks, it gives you the lowest, the coldest temperature, but you need a lot of armamentarium for this one. You need a carbon dioxide tank and a special ice maker equipment in which you make those small dry ice crystals. So that's something not too easy to do in a clinical setting. So that's a big disadvantage of carbon dioxide sticks, but still, I would tell you, some people use it in their clinics. Next comes endo ice or tetrafluoroethane, also DMD, which is an older one, which is dichloro-difluoromethane. These are at negative 50 degree, but then how it works is we take a small cotton pellet on a tweezer and we shake our endo ice bottle and we spray a little bit on the cotton tweezer. By the time we are doing it, it falls to negative 20 degrees centigrade. So that's more desirable. Like, you want to stay closer to or a little bit above 0 degree, which is going to be ideal. So in that way, endo ice works great for us as a clinician, and it's most efficient, most easy, most commonly used pulp test, and it's a primary pulp test. So this is going to be your first choice if you are going to pick among all kind of cold tests. Endo ice is going to be something that you really prefer. After endo ice, ethyl chloride spray is totally gone out of the market. We don't see it much often anymore, but if it is in the market, then yes, it's something that you can use instead of endo ice. I did not find any disadvantages for using ethyl chloride. It's just that it's not used anymore in the market. Endo ice has completely taken over because it's way more efficient to do with endo eyes. Last is eye sticks. So yes, you can, it's easy to make. There is some kind of frames that you can use to make those eye sticks and keep it in your clinic freezer and use it when the patient is there. But when you are applying it, the temperature of the eye stick may fall above 0 degree, may rise above 0 degree, which is not desirable. And that's all about cold test. So these are all 4 cold tests. I hope this topic was clear for you. The most important thing to remember here is endo eyes is the most common, most efficient, most easy to use. Eye sticks never give you 0 degree in the patient's mouth. They always fall just little, or always rise the temperature a little bit above 0 degrees. And the carbon dioxide sticks, or the dry ice sticks, or CO2 sticks, are the one with the lowest temperature, which is negative 78 degrees. And you need a special equipment to make it. I hope that's clear. I think you will remember this one. Something to know that the cold tests are more effective on anterior teeth than posterior teeth. Then you have to know, what if the patient has a crown on their tooth? In that case, cold tests are the most efficient, most effective in reducing temperature within the chamber under full coverage crown. They're not just saying that the cold test is the most effective on a crown tooth. They are saying that the cold test is most effective in reducing the temperature within the crown chamber, because maybe there is all composite, maybe there is all amalgam, there is not even much tooth structure. But so they are being safe on that side, and they are trying to say that on a full coverage crown, it reduces the temperature inside the crown. So that's why it's most effective that way. You cannot do an electric pulp test on a crown, and if you warm up gutta percha and just apply for the heat test, then that's definitely not going to work much on a crown tooth. Gingival recession and attachment loss decrease the sensitivity to cold testing surprisingly. Now, this is just coming from a very common question asked in dental board exams, that and the topic that they are trying to test you on is if the patient has gingival recession and attachment loss. You would think that the gingival recession happened, so now when I apply the cold test, it will work much more. When I apply the cold test, like my endo eyes cotton palate, then the patient would definitely feel more response, because now the gums are gone, so it's gonna feel it more. Surprisingly, ironically, or paradoxically, it decreases the sensitivity to cold test when there is attachment loss or gingival recession. So remember this point. It may someday show up on your board exams, and this is going to be the answer that you might feel an impulse to answer the one which says it will increase the sensitivity to cold test. The answer is it decreases the sensitivity to the cold test. And next is, when do you get a false negative and a false positive on a cold test? So false negative is when applied to a teeth with pulpal calcification. If the tooth is calcified, the pulp chamber is calcified, there is not much nerve tissue present in the pulp because there is no pulp, or it's calcified. So that cold sensitivity will not be conveyed down to our nervous system, so we might not feel it much. So it may give us a false negative. So it may give us a false negative when applied to a tooth with pulpal calcification. And it may give us a false positive, like it's not positive, but still you are feeling that it's positive when applied to the gingiva or adjacent vital teeth accidentally, because it's a cotton palate. It's quite a big size palate, and you're holding with a tweezer. And if it's like the second molar in the lower arch or upper arch that you're trying to test, you might accidentally, and maybe that tooth is non-vital or vital, but you may accidentally touch that cotton palate on the gingiva or on the tooth surface of the adjacent tooth, and you might get a false positive. So be careful with that one as well. Hence, we only apply to incisal or mid-third of the tooth. And that's a common question asked in board exams, that it is just one of the option in one of the questions in the release set in NDEB questions, that where the cold test is applied on the incisal edge or the middle third of the tooth only. We do not apply it to the gingiva of that tooth, otherwise we'll get a false positive. We do not apply it to the adjacent tooth or the mesial and proximal surface. Interproximal, like I would try to go interproximally and test it. No, you will touch the adjacent tooth and you might get a false positive. So that is about false positive and false negative using a cold test. All right, let's talk about heat test now. So it's not very often used because it is only used when the patient has a chief complaint of pain with hot coffee or any hot drink. Other than that, if the patient do not complain of heat, then we do not give a heat test. There are some research which shows that inducing heat to an inflamed pulp may actually damage the pulp further, so we might do more harm to the patient than we are doing benefit. That's why we only try to do heat test when the patient has a complaint of pain due to heat or a symptom of pain due to heat, which comes from their history, of course. Performed using heated gutta percha. So there are some gutta percha sticks and you heat the front of it and then you apply it on the incisal or the middle third of the tooth. There is a dry prophy cup. You run that dry prophy cup without anything on a dry tooth so that it creates some frictional heat there, which is not something we use very often anymore. And then irrigate syringe. You take hot water in a syringe and then you try to apply that hot water on a single tooth. Now just think about it, how much it's going to work. It's gonna go on the adjacent tooth as well. So there is no way you can keep a control tooth. Some people say, no, you can use a rubber dam. Use the rubber dam and then irrigate hot water on it to find out does the patient reply to it. Now think in this way, I'm gonna give my patient local anesthesia to apply the rubber dam. How can I ever test if the tooth is vital or non-vital when the rubber dam is on? So somehow this is not a very good test unless that's the only lone standing tooth around there. If there is no tooth mesial or distal to that, it's just one lone standing tooth, then yes, you can perform a heat test using hot water irrigation. If the patient says prolonged sharp pain which lingers even after removal of stimulus, it is indicative of symptomatic irreversible pulpitis. Just throwing it in there because it asked in one of the questions in the national boards, but I will discuss symptomatic irreversible pulpitis more in detail later in this course. Now, heat tests are responsible for activating the C fibers. The heat test activates the C fibers and it may give a false positive with a necrotic tooth sometimes. And there are other cases where the heat will actually relieve the patient from the symptom. If the patient has extreme symptom, the symptom is relieved by heat, then we will know what exactly the diagnosis is going to be for that one. So for that condition also, sometimes people use heat test. It straight come from the history of the patient, so you don't have to. But when do we get a false positive with the heat test? It comes when the tooth is necrotic, then sometimes we can get a false positive. Quiz for you, when do we get a false positive with a cold test? I'll give you 5 seconds to think. 1, 2, 3, 4, 5. The answer is when we accidentally touch it to the gingiva of the tooth or to the adjacent tooth. So what do? We always keep it on the incisal or the middle third of the tooth. Great, if you remember, that's awesome. Some important points about both cold or heat test. If you are performing a cold or heat test, it activates the thermodynamic forces within the dentinal tubules. And once you do that, it excites the intradental A delta fibers, less commonly the C fibers. So this research has been going on for a long time. Tons of papers have been published, and that's where we are trying to come to a conclusion with a systemic review study that it excites A delta fibers more and less commonly the C fibers. The C fibers are generally not activated by cold test, heat test, or EPT. The C fibers are associated with tissue injury only. If we test properly, then there will be no pulpal injury which activate C fibers. Heat test could be more damaging to the pulp when compared to the cold test. A few important things to take home in this whole slide is first that both hot test or heat test and cold test are actually working on A delta fibers, not on the C fibers. Number 2 is C fibers are mostly activated when there is an injury or when the pulp is hurt. And number 3 is heat test can be more damaging to the pulp tissue compared to the cold test. And that's why indirectly we try to remember it in this way that do not perform heat test unnecessarily on a tooth if the patient's chief complaint is not pain or any symptom due to heat. If the patient's complaint is symptom due to cold, then just do the cold test and EPT, skip the heat test. Heat test is only when the patient's complaint is for heat. Otherwise, you are doing a little bit damage to the inflamed pulp rather than fixing it. But again, some studies also say that if we test properly, there will be no pulpal injury, which activates the C fiber. So these two are some contradicting opinions, and I would just want you to remember both so that if the question shows up in the exam, you know how to tackle that one. Alright, so next one is going to be electric pulp test. So electric pulp test is a small machine, if you have not seen it, which comes with a straight wire, and then there's a hand piece, or the piece that we hold in our hand, there's a clip on. The clip, we try to put it on the patient's lip or somewhere on their body part. So that works as a way to complete the circuit. And we take the probe. There's a probe tip on the handpiece, and that probe tip would just touch on the tooth surface, while the current will flow from tooth to the clip on the lip of the patient and then complete the circuit. And that's how we know if the pulp tissues are vital, then the current will flow. If the pulp tissues are dead, it's necrosed, then there is no potential in the pulp to pass the current through. So that's the phenomena, or that's the background behind the electric pulp tester. And it measures the response by the pulp to flow of an electric current. EPT denotes the viability of nerve fibers, if they are living or if they are dead. EPT does not indicate the level of pulp inflammation. And the funny thing is, the electric pulp test has a small digital meter. It gives you number from 1 till 80. And the number 1 till 79 has only single meaning, which is the pulp is vital. And the last number, which is number 80, has a single meaning that the pulp is dead, according to the EPT. And we never consider it the most foolproof way of diagnosing endodontic condition. But still, 1 to 79 is all the same thing. It does not mean that if one tooth has a reading of 20, other tooth has a reading of 50, another tooth has a reading of 79, they all are considered vital, while the tooth with a reading of 80 is considered non-vital. So it does not indicate level of inflammation, how inflamed it is, what is the level of the current flow. Ignore all those things. Just stay with, is it 1 to 79? Then it's vital. If it's 80, then it's non-vital. EPT does not differentiate between pulpitis and vitality. So EPT will be useless to say that this pulp is normal, this pulp has irreversible pulpitis, or this pulp has reversible pulpitis. It cannot differentiate between them. It only differentiates between either the pulp is vital or the pulp is necrosed. Repeating the same thing again. Only accurate and definitive response is no response. So if the tooth is not giving response to the EPT, that is the only correct response. If you try to touch the EPT probe and the patient says, "Oh, I feel pain," that does not give you any inference from that test. It does not say anything except that the pulp is vital. The only use of EPT, only accurate response of EPT is no response. That's when it's definitive that the pulp cannot pass the current through. That means the pulp is non-vital or pulp is necrosed. No response is the only true response. It is useful to indicate pulp necrosis only when no response. The current is gradually increased until the patient feels warm or tingling sensation. At this point, a reading is recorded. The highest number on the EPT is 80, which indicates pulp necrosis. From 1 to 79, it all means one thing, that the pulp is vital. Some points to remember: will work only when probe is placed in contact with the natural tooth surface. What does that mean? You cannot keep it on the amalgam, you cannot keep it on a PFM crown, you cannot keep it on a gold crown or anything like that. If a natural tooth structure is not available, example case of full coverage crown, or sometimes there is a full coverage onlay or something like that, then an alternative pulp testing method is used, such as cold test. We discussed earlier, cold test is the best test method when you have a full coverage crown, because it can bring the temperature inside the crown pretty low, while EPT, electric pulp tester, would not give you any result in a full coverage crown case. EPT produces false positive or false negative response 10 to 20% of the time. And EPT is not used if the patient has a pacemaker. It does not, like the new generation EPTs are safer, but for the sake of exams, try to remember that if the patient has a pacemaker, then we avoid using electric pulp tester. Do not use when apex is open. If the patient is a young patient and there is no apex, like apex is completely open like that, it's still in the growing phase, then we do not use EPT. It does not give us a correct response. It's rather we used a cold test or endo ice with cotton palate to confirm the diagnosis. You will see a false positive in electric pulp test when the pulp is partially necrosed. So you would feel that it's positive because the current is going through, but maybe this root has two canals. One of the canal is completely necrosed while other canal still has some viability. So it may give you a false positive, but it is not correct. If the patient has high anxiety, then they just jump on anything that happens, any kind of feeling. So anxious patient may give you a false positive. Ineffective tooth isolation can give you a false positive, and contact with the metal restoration such as crowns or amalgam can give you a false positive. What will give you a false negative? A calcified or obliterated root canal. It may be vital, but it's calcified. Like the top part of the pulp chamber is calcified. Maybe there are vital tissues down in the canals, but if you do the EPT, it may not let the current pass through the calcification. So you might get a false negative, but the tooth is vital. You might get into trouble later, and you might have to change your approach to the vital root canal treatment. A recently traumatized tooth, never do EPT. This is a very common question. They keep asking that a patient just had a trauma last night on the tooth. It is painful, and when the EPT was done, it gives a negative response, or it gives a response of 80. You do not trust an EPT right after a traumatic injury to the pulp. You have to wait for a certain time, or you have to perform other tests before you confirm to a diagnosis. But for a traumatized tooth, a recent trauma, EPT is not trustable. It can give you a false negative. Immature apex, just we discussed earlier. If the patient is young patient and the apex is not closed, then we do not use EPT. Poor contact of the pulp tester. If you did not make a contact, you may get a negative response. Drugs affecting patient's pain threshold can also affect EPT. So I have two studies. One comes from my university and one comes from another institute that I joined to prepare for the AFK exam. And they both have similar conclusion, but the study was done to differentiate between cold test, EPT, and heat test. And it says, the first study says that 86% of the time, cold test was successful, and heat test was the least successful in 71% of the time when it comes to efficacy and accuracy of the test. Second study says cold test is accurate 90% of the time, while heat test is accurate 84% of the time. Overall, what we can say is cold test is most sensitive in representing vitality of the pulp. Once again, cold test is most sensitive in representing vitality of the pulp. Another special kind of pulp testing option is test cavity preparation. Now, test cavity preparation involves creating a class 1 cavity on the tooth without giving any local anesthetic. It somehow, with rubber dam and everything else, it starts getting little doubtful for the clinician. But if there is, like, the tests are not giving you any response, if the pulp tests are not working for you, you cannot trust it, or you are thinking that pulp test says it's non-vital, but I'm still not sure, what should I do? Then you would start with a class 1 cavity prep. So the test cavity prep is done when the necrosis is confirmed radiologically, and other tests also give you that diagnosis, but you're not 100% sure that if there is necrosis, then you will go ahead with a test cavity preparation. And how it works is you create a small class 1 cavity prep without giving local anesthetic to the patient. You start that preparation. If the patient is going to respond with some dentinal sensitivity and you are feeling that, oh, patient is getting discomfort, or patient can start raising hand, then you know that this tooth is actually vital no matter what other tests are saying. If the patient feels pain or sensitivity, stop the cavity prep test and fill the cavity with a correct restoration. So that is another kind of special test, but it's also a pulp vitality test that can be used. Next, pulp vitality test, which again is a special test, but it can be used to detect pulp vitality with 100% accuracy, is a blood flow determination using laser, doppler flowmetry, or pulse oximetry. There are two different ways of doing this blood flow determination. This is the most accurate, like 100% accurate. So if you see 4 options, then you have to select this one to be 100% accurate pulp testing. It is least used or least preferred because it's not even practical. You have to go to some university or some lab settings where you would detect it, and why would you do that? And there is a sensor applied to both facial and lingual surface, and the blood flow is shown as beam of light with a dual wavelength spectrometry. And there's also laser Doppler pulse oximetry, in which we detect the hemoglobin levels using pulse oximetry. If you want to detect the pulsations in the pulp, then you use laser Doppler flowmetry. So these are the two things that you might want to remember, that if you are detecting the oxyhemoglobin in the pulp tissues, then you are using the pulse oximetry. But if you are detecting the flow of the blood, then you are actually going for laser Doppler flowmetry. So very specialized, very impractical, but something which is 100% accurate. So boards would love to ask you this question, so just keep it in your pocket. So this was just another video of the complete endodontic diagnosis series on my YouTube channel. So just go on the playlist section and follow along the entire playlist to master endodontic diagnosis for dentistry exams, which include national boards of USA, Canada, ADC, as well as NEET PG exams. And make sure you post in the comment section below if you have any questions around this topic. Subscribe to my channel, share this video with at least one friend, and I'll see you in the next part of this series.